Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. This is the eighth presentation series, and we're dealing with Pulmonary Mechanics Part 3. So this is the Great Adventure, and here we're number 8 in our series. We want you to approach this with the enthusiasm of a kid in a candy shop, and remembering that what we're talking about mechanics here is that this is what determines the distribution of ventilation. And of course, if you go back further, it was changes in VQ within the lung that result in a lot of gas exchange abnormalities. So only two things: decreased distensibility and airway obstruction. And we really talked about compliance and resistance. Remember that airway obstruction, if it's extrapulmonary, is primarily an inspiratory problem. You have to generate an increased negative pressure to get flow by this obstruction, and there can be dynamic collapse of the airway during inspiration if pressure inside is less than pressure outside. During exhalation, however, airway pressure is positive. In fact, this is not an issue. So extrapulmonary airway obstruction is an inspiratory problem, and clinicians know this as stridor, an inspiratory sound. We're going to be talking again primarily about intrapulmonary airway obstruction, and here during inspiration, you're actually expanding the lungs with negative pressure in the lungs during inspiration, but the pressure outside the lungs may exceed the pressure inside the lungs, as we talked about with equal pressure point theory, during exhalation. So intrapulmonary airway obstruction is an expiratory phenomenon, and clinicians know this as wheezing during, for example, asthma, CF, and chronic bronchitis. Let's first talk about the distribution of ventilation, perfusion, and VQ within the lung. And we're going to talk really about the normal lung here. Right? So remember, compliance is change in volume over change in pressure, and resistance is change in pressure over flow. So it turns out that there is a pleural pressure gradient within the lungs. And this can be viewed kind of like a slinky. If any of you as children played with these springs, if you hold them up at one end, they kind of stretch down and bunch up at the bottom. Well, the lungs actually do the same thing inside the chest. So that in general, most adults, we estimate about a 30 centimeter height of the lung in the upright position. And intrapleural pressure basically is highest at the apex, about minus 10 centimeters of water at rest, okay, or at FRC, and down to only -2 at the base of the lung. Again, here the lung tissue is stretched out, more recoil, if you will. Here it's kind of bunched up, less recoil. So the lungs work the same way. So remember the two roles for elastic recoil. Yes, elastic recoil does decrease lung volume and cause exhalation to be passive, but its more important function is to support the patency of intrapulmonary structures when lung volume is fixed. So, of course, if lung volume is decreased, you have less support here and the structures are smaller. If you have higher lung volume, then the pull is greater and the structures are larger. Here's what we have. In an upright lung, okay, at let's say FRC, which is the lung volume you're at the end of a normal exhalation, the structures are larger because there's more pull here on elastic recoil, and so this alveolus at rest is going to be larger than down here at the base. However, it means that there's less room for this to expand up to its maximum volume, right? And conversely, there's more room for this to expand to its maximum volume. So structures are initially larger in the apex, but ventilation is actually less. Structures are initially smaller in the base, but ventilation is actually greater. And this is plotted on the flow volume curve here. So you can see that up here, we're in this flattened portion of the curve. For a certain amount of pressure, you don't get much volume. But down here, on a more optimal portion of the curve, even a modest amount of pressure, you get significantly more volume. That is kind of a difference in ventilation throughout the lung. Gravity affects the distribution of ventilation in normal lungs by alterations in pleural pressure, elastic recoil, compliance, and resistance. In lung disease, pathologic changes in compliance and resistance have a greater effect on distribution of ventilation than even gravity. If we look at the vasculature, what about the distribution of pulmonary blood flow. So here we have blood entering in the pulmonary artery unsaturated. It enters the pulmonary capillary, diffusion occurs, and it exits the pulmonary vein saturated. Whether this blood vessel is open or not depends on its relationship to alveolar pressure. So we have three pressures to deal with. We have pulmonary artery pressure, alveolar pressure, and venous pressure. In the lung, it turns out that there's also a gradient in intrapulmonary vascular pressures. So blood enters the pulmonary circulation at the hilum, which is about halfway up or down the lung. Normal individuals, we assume that this height is about 30 centimeters. So this means that the blood pressure, pulmonary artery pressure at the bottom of the lung is equal to mean artery pressure plus the weight of a column of blood 15 centimeters high or 11 millimeters high. So that pressure down here is actually going to be mean arterial pressure plus 11. Pressure up here, conversely, is going to be the opposite. It's going to be mean arterial pressure minus 11. Okay, so there is a gradient in pressure in the lungs. And this actually sets up three zones of pulmonary perfusion in the lungs, originally described by John West. So at the top of the lung, arterial pulmonary artery pressure is the least. Okay, so that alveolar pressure, which is constant pretty much throughout the lung, is greater than arterial pressure and greater than venous pressure. And this means that this vessel is squished and essentially there is no flow. So we're plotting flow kind of on the horizontal axis here. However, as we decrease in height, okay, in the lung, what's happening is that pulmonary artery pressure and pulmonary venous pressure are increasing. So it gets to a point where pulmonary artery pressure now starts to exceed alveolar pressure. And this is so-called zone 2 of the lung. And in this case, flow is determined by the difference between pulmonary artery pressure and pulmonary alveolar pressure. So because pulmonary alveolar pressure remains constant and this continues to increase, that flow increases as we descend. Then we get to a point where both arterial and venous pressure are greater than alveolar pressure. And then flow is determined by the difference between arterial and venous pressure. And there's a slight increase in flow because vessels distend, but not as great as in zone 2. So these are three zones of pulmonary perfusion. Now, it is believed that every individual does have some zone 1, probably not this much, but some zone 1 of lung perfusion, ordinarily at rest at least. So just to summarize, zone 1 in the apex, alveolar pressure equals both arterial and venous pressure, there's no flow. In the middle of the lung, arterial pressure exceeds alveolar pressure, and flow is determined by that difference. So there's some flow and it increases. And then at the base, there's arterial and venous pressure both exceed alveolar pressure, and that has the greatest amount of flow. We can plot now the change in ventilation and the change in blood flow from the base to the apex of the lung. So we said that ventilation is greatest at the base, less at the apex, but the slope of this line is not that great. Blood flow at the base of the lung is considerably greater than blood flow at the apex. So the slope of this line is in fact greater. If we now divide ventilation by perfusion, we get the slope of VQ, which looks like this, right? So it actually has a lower value at the base and increases into the apex. So this is the distribution of ventilation, blood flow, and VQ in the normal lung upright. Or just looked at again. At the apex, ventilation is decreased, but perfusion decreased more, so VQ is greater. At the base, ventilation is increased, but perfusion is increased more, so VQ is decreased. Remember, VQ determines gas exchange. So if we actually look at PO2 and PCO2 in the lung, PO2 is highest in the apex and lowest in the base. PCO2 is lowest in the apex and highest in the base, following basically the VQ differences here. So again, apex, VQ higher, PO2 higher, PCO2 lower. The base, VQ lower, O2 lower, PCO2 higher. If you've got somebody with non-uniform lung disease, let's say bad lung disease on one side of the chest and reasonably good on the other side, Do you want to put that good side up or down? While looking at this graph, both ventilation and perfusion are increased at the base of the lung, the dependent portion. Thus, the good lung should be down, right? Now, this was a study done in Brazil, and what they did was use inhaled radioactive materials. And so, in patients who were, in this case, lying with the right side down, when they inhaled materials, more went into the bottom or lower portion, and conversely, when the patient was left side down, more went into the lower portion as well. This just shows the numerical values that there were significant differences in the amount of radioactive deposition here, whether the right side was up or down. So right side down, much more than on the left side, which was up. Left side down, much more than the right side, which was up. So both ventilation and perfusion are increased at the base of the lung or the dependent portion. Ventilation is decreased in the independent lung, thus the good lung should be down, generally speaking. How about prone positioning? So we've heard about this primarily during the COVID-19 epidemic. So one of the most effective strategies to improve oxygenation in patients with moderate to severe ARDS, which is defined as a PaO2 over FiO2, less than 150, it improves survival, probably mostly because it decreased ventilator-induced lung injury. Prone position was started early for about 16 hours a day. It doesn't seem to be as effective in children as in adults, but it is recommended as first-line therapy. But how does it work? So the lungs are compressed by the heart and abdomen in the supine position, resulting in some lung collapse. There's less lung collapse in the prone position. The mechanisms to direct blood flow to different portions of the lung are disrupted in ARDS, and so the prone position redistributes blood flow and ventilation more evenly. Improved lung function in prone reduces ventilator settings, therefore reducing ventilator-induced lung injury. And prone positioning may improve heart function by increasing blood return to the right heart. Because the mouth and nose are facing down in the prone position, secretions produced by the disease process, may also drain. So this just kind of shows a diagram here. So in the supine position, you can see the heart here, lung here is kind of collapsed in the bottom sort of thing. Ventral alveoli are overdistended and dorsal are collapsed. In the prone position, there's a more uniform improvement, and so that there's basically decreased collapse in the front or back position, and so that basically less ventilation is required and blood flow is increased throughout the lung. Prone tends to even out the distribution of ventilation. There were studies showing that proning up to 36 hours were safe and had more impact on oxygenation than 16 hours. And I think you can see here that the PO2 over FiO2 ratio, and again, high is better, improved a bit more in those patients after during and after pronation. To this point in time, again, we've talked about the fact that VQ affects ventilation. Increased VQ, increased oxygen, decreased CO2. This ventilation is affected primarily by decreased sensibility and or airway obstruction that causes regional differences in ventilation. So let's now talk about worker breathing. In high school physics, you probably learned that work equals force times distance. If we multiply top and bottom of this equation by area, we do not change the equation. And then redistribute, so we've got force over area times distance times area. Force over area is pressure, distance times area is volume. So in the respiratory system, work equals pressure times volume. All right. So this, if we look at a pressure volume curve, this red area is the work of breathing. All right. Now it's actually divided in two parts, which we'll talk about here in a second. So if we're talking about work of breathing, generally, we're going to be talking about pulmonary compliance, all right, or looking at transpulmonary pressure is the pressure that we're talking about. All right. So remember the equation of motion. So for transpulmonary pressure, we need to overcome an elastic component and a resistance component. Let's look at an analogy here. So let's say I've got a heavy block of something on ice, and the reason for that is to minimize or eliminate friction. I can pull this spring. It's going to take me some effort. I can put more and more effort and so on. And I can plot this. So here's the resting state. Here I pull the spring out a little bit, make a little bit of distance, sorry, but I required some force to do that. Here I've put more force in, got more distance. Here put more force in, got more force. This triangle is the work that I had to do to extend that spring. All right, so that's frictionless, and that's kind of like inflating lung volume, okay, elastic recoil. Now, if I repeat the same experiment, but now have this block on gravel, all right, now there's considerable resistance when I pull this that I have to overcome. So now when I pull the block out here, I not only have to do the work against the spring, but I also have to do some extra work to move this block over gravel. Extend it out here, same thing. More work to extend it over gravel, and finally more work to extend over gravel. So this shaded area is actually the work I did to overcome resistance or to overcome friction. This trapezoid, the red trapezoid, is what was required to overcome elastic work, to overcome volume. This blue area is what was required to overcome resistance. If I have restrictive disease, stiff lungs, then the work that I have to do to overcome elastic recoil may increase like this. Resistance work won't change. On the other hand, if I have obstructive disease, elastic work might not change, but the resistance work that I have to do increases significantly. Okay? Basically then, using this equation of motion, we can calculate again what the PEL is, its volume over compliance by this curve, and resistance is, the resistance component is resistance times flow. So this equation of motion is that transpulmonary pressure is equal to volume divided by compliance and resistance times flow. I think you can understand if you have stiff lungs, you have low compliance, this is going to be a very large term. On the other hand, if you have high resistance from airway obstruction, then flow times that large number will be a high term. So this actually helps determine the pattern of breathing. In a normal individual, one might breathe, reasonable tidal volume and a reasonable rate. If you have restrictive disease, you don't want to try and expand that stiff lung. That requires a lot of work. So you'd rather generate a rapid, fast breathing pattern. Conversely, if you're obstructed, you don't want to generate rapid breathing. You don't want high flows. You want relatively low flows, but you're willing to take in higher volumes. So these breathing patterns are characteristics of normal, restrictive, and obstructive disease. Basically, just to summarize, for stiff lungs, you want to minimize the elastic recoil component. So you're going to take rapid, shallow breaths. For airway obstruction, you want to minimize the resistance component of transpulmonary pressure. So you're going to take deep, slow breaths. And this again is from the equation of motion of the lung. Measuring metabolism. How much work is involved in breathing? So this plots a normal individual during an exercise stress test. And what you can see here is as this person exercises harder, the VO2 is increasing. This person is obviously increasing ventilation. So this is total metabolic rate that increases with exercise. But this red portion, this red sliver, is what was required to breathe. This is what basically is fueling respiratory muscles to perform work of breathing. It's not much of the total respiratory load for a normal individual. If you have someone with significant lung disease, let's say this patient with chronic obstructive pulmonary disease, right, this person doing the same exercise study, but note he doesn't get up nearly as high an O2 consumption as the normal individual, and his ventilation doesn't get as high. But look at how much of his total metabolic rate now goes into work of breathing. About a third. So about a third of this person's total metabolic rate is now involved in work of breathing. So for normal individuals, work of breathing is not much. But if you have significant lung disease, it can be a significant portion of your total metabolic rate. How do we measure this? So generally speaking, metabolic rate is measured by indirect calorimetry. So resting energy expenditure, or sometimes called resting metabolic expenditure, equals by the De Waer equation. It equals 3.9 times oxygen consumption plus 1.1 times CO2 production. Now, generally speaking, we're doing this in an indirect calorimeter. So we're sucking in room air, with an inspiratory volume and an inspiratory FiO2, inspiratory volume, inspiratory FiCO2, which happens to be 0. And then measuring exhaled ventilation times mixed expired oxygen and exhaled ventilation times mixed expired CO2. So this is what some of these commercial devices look like. Okay. So this kid, again, we're sucking air out in this case, but air is coming in. And we're going to basically measure the exhaled air. Well, oxygen consumption equals inspiratory ventilation times FiO2 minus expiratory ventilation times Fe, that's mixed expired oxygen. Okay, so that's the equation for that. The calorimeter draws in exhaled gas, that is, it draws it in to analyze. We don't know inspired ventilation. Does minute ventilation equal exhaled minute ventilation equal inspired minute ventilation? And can we measure inspired ventilation? We need it for this equation, right? It turns out that we can use or think about R. So R is the ratio of CO2 production divided by O2 consumption. If R was 1, then O2 consumption would equal CO2 production and inspiratory volume would equal expiratory volume. However, the normal value for R is about 0.8 at rest. Thus, this cannot be assumed to be a constant. But can we calculate this? So there's another gas we haven't talked too much about, which is nitrogen. Nitrogen is neither excreted nor absorbed. Thus, nitrogen inhaled must equal nitrogen exhaled. Inspired ventilation times inspired nitrogen equals expired ventilation times exhaled nitrogen. And so we can reconfigure this and we can calculate inspired minute ventilation as expired ventilation times the nitrogen ratio, that is exhaled nitrogen over inspired nitrogen. So then we can go back to our equation and we in fact can get an equation for oxygen consumption where we can measure all of these parts, okay, by indirect calorimetry. In the computer era, this is often done for you. The good news is that global warming and greenhouse gases aside, the fraction of inspired CO2 is essentially 0. So we don't really need to worry about VI for CO2. VCO2 equals exhaled minute ventilation times mixed expired fraction of CO2. All right, so that's the formula there. So we can measure these things, all right? And this is the formula overall if we've measured O2 and CO2 to get resting energy expenditure in terms of kilocalories per day. This has been used in a number of contexts. So there's a test historically called the basal metabolic rate, or BMR. This is rate of energy expenditure per unit time by endothermic animals at rest. And the proper measurement requires a strict set of criteria. They need to be in a physiologically and psychologically undisturbed state. They need to be in a neutral thermal environment. They need to be in a post-absorptive state, that is fasting, not digesting food. And body temperature should be measured during this test. Nobody really does, well, I won't say nobody. This test is rarely performed anymore. And actually, it was originally developed as a measure of thyroid function before they could easily measure blood thyroid levels. We do a modification of this called a resting energy expenditure, or REE. And the criteria here is that we ask people not to eat or drink anything except water for 4 hours prior to the test, not a full 24-hour fasting. Not to exercise for 48 hours prior to the test. And then rest comfortably supine while awake. Ideally should not fall asleep during the test. And we take a 20-minute period prior to the test and then collect data for 20 minutes. Results are still valid if you have at least 10 minutes. This was used by 2 of our former fellows, Sharon then Kersner, now Isanaka, and Mina Gard. And they wanted to look at growth failure in BPD. And the question is, we have babies with bronchopulmonary dysplasia, some of whom fail to grow. Is it because they don't eat as much? Is it because they burn more calories, have an increased metabolic rate? Does worker breathing increase metabolic rate? And does this result in fewer calories available for growth? These are Mina Garg and Sharon Kersner, now Sanaka, who were postdoctoral fellows in neonatal perinatal medicine with us in 1985 to 87. And they did this very elegant study. They studied 6 infants with BPD that had growth failure, and they studied 7 infants with BPD who had normal growth. Gestational age was worse in the babies with growth failure, 27 weeks versus 30. Birth weight was a bit lower, 980 grams versus 1390. Days on mechanical ventilation were more in the growth failure group, and days on supplemental oxygen were more in the growth failure group. So they constructed actually an indirect calorimeter where we had a baby in a hood. We drew gas out. There was a mixing chamber. There was a pneumatic to accurately measure flow. We had a mass spectrometer to actually measure O2, CO2, and nitrogen concentrations. There was a suction fan to generate this flow. And here's what they found. We had controls who were not BPD babies, and controls had an oxygen consumption at rest of about 7 mLs per kilogram per minute. Normal growing BPD babies had about the same, but the growth failure BPD babies had almost 50% higher oxygen consumption at rest. Similarly, if we measured metabolic energy expenditure in kilocalories per kilo per day, again, controls and normally growing BPD babies were about the same, but BPD babies with growth failure had a bit over 50% increase in resting energy expenditure. Interestingly, oxygen consumption at rest in the control infants did not correlate with body weight. So you can see that there was no difference here. But in the BPD babies, it did. So those babies who were smaller had a much higher oxygen consumption at rest than those who were larger. If we looked at oxygen consumption versus dynamic pulmonary compliance in these babies, you can see that those babies who had the highest oxygen consumption also had the lowest dynamic pulmonary compliance. That is, their lungs were stiffer. In this study, they showed that babies with worse lung disease actually had more metabolic rate. So these studies show that growth failure can occur from an increased metabolic rate due to lung disease. And abnormalities in lung disease can increase work of breathing to the point that metabolic rate is increased. All right, let's quickly talk about lung development. The first developmental pulmonary physiologist was actually William Shakespeare. And as you like it, he said, and so from hour to hour we ripen ripe. He's talking about pediatrics. And then from hour to hour we rot and rot. He's talking about internal medicine. And thereby hangs a tale. So you're all glad you're in pediatrics where things are improving with time. So children are not just small adults. And lung development occurs in a series of stages. So in utero development, embryonic, one just has lung buds, if you will, and the trachea and bronchi basically differentiate, and you start to get a pulmonary vein and artery. Pseudoglandular is, so this is up to 7 weeks, sorry. Pseudoglandular is 7 to 17 weeks. Here you get conducting airways, terminal bronchioles, immature neural networks, and preacinar blood vessels. So this is the point when conducting airways are finished at about 16, 17 weeks of gestation. Canalicular phase, primitive alveoli form, type 1 and type 2 cells, and surfactant synthesis starts. 27 to 36 is saccular. So here we start to see alveolar saccules, extracellular metrics, and then finally birth really is the so-called alveolar phase when we expand the gas exchange area, nerves, and capillaries. And this continues until now we understand about 18 years of age. While most lung growth occurs in the first few years of life, lung growth by adding alveoli does continue, certainly past puberty, to about 18. This is just work of Lynn Reed, who's famous for this, who showed, again, a 16-week gestation, preterm infant, really doesn't have much in the way of structures. By 19 weeks, you're starting to get respiratory bronchioles. By 28 weeks, you have alveolar saccules, terminal saccules at birth, or alveoli here. 2 months, a little bit more. 7 years, a little bit more. So development basically occurs in that sort of fashion. What's plotted here is relatively more recent data showing a log number of alveoli. And so you can see that a normal full-term infant is only born with about 10% of alveoli, so that 90% of alveoli are added after birth. And you can see this is somewhat exponential in this way. Most of this occurs in the first maybe 3 to 5 years of life, but there still is addition, since it's a log scale, still is addition out to puberty and beyond, probably. So humans have only 10% of alveoli at full-term birth. Preterm infants have even less. 90% of alveoli are added after birth, so this growth may repair lung injury that occurred during infancy. And growth increases surface area available for gas exchange. So remember, that's a main thing about lung structure, is surface area available for gas exchange. Right? And remember, in an adult, you have about 75 square meters or 90 square yards, which would look like this from a single person on the USC football field. Similar types of lung injury cause different diseases at different ages. One exciting thing about pediatrics. Classic example is RSV, causes life-threatening bronchiolitis in infants, but usually only a benign, relatively minor upper respiratory infection in adults. Lung injury occurring early in life may alter development, causing abnormalities which persist into adult life. And let's just look at a few examples. This is a study that looked at lung function in terms of maximal potential of an individual born to term and individuals born prematurely. And what one can see is that some of these tail off here and get significantly worse with increasing age. We're up here to adult life. So David Botter, who's a postdoctoral fellow in pediatric pulmonology, here in 1985 to 87, he did a study looking at school-aged children, average age 10, who had BPD as infants, but who were not being followed in pulmonary clinics. So they were asymptomatic and controls. Age was the same. Estimated gestational age by design was less in the BPD than the controls. Birth weight was less by design. Days on ventilation, obviously controls were not on ventilation or oxygen. And this is what he found. Between the BPD and controls, no difference in total lung capacity. Vital capacity was significantly lower in the BPD babies, and residual volume, or hyperinflation, was significantly higher. The ratio of residual volume to total lung capacity was significantly increased in BPD. Measures of airway obstruction, FEV1, and FEV25-75, we'll talk about these in more detail, were significantly decreased in BPD. Vmaxes we'll also talk about, our flow rates corrected for lung volume, were also decreased in BPD compared to the controls. These kids were exercised with a standard cardiopulmonary exercise stress test or graded exercise stress test. The maximal heart rate achieved between the two was not significantly different, right? And the maximum R was not significantly different. The decrease, however, following exercise was greater in the BPD babies, and 50% of these babies had exercise-induced asthma following exercise compared to none of the controls. He basically showed that BPD kids, even as asymptomatic children, have relative abnormalities compared to controls. Soumya Swaminathan did a similar study. She was a pulmonary fellow with us, 87 to 89. And she studied babies who are children who had Meconium aspiration syndrome as infants. And again, they were 11 Meconium aspiration, 9 controls. Age 8, time of study, estimated gestational age and birth weight were about the same in this group. And she showed, again, no difference in total lung capacity or vital capacity, but there was hyperinflation. There was no change in the standard spirometry. But if we look at those flow rates corrected for lung volume, they were significantly lower in the aspiration group. Closing volume was higher, which is bad, and slope of phase 3 was not significantly different. So these kids also showed evidence of airway obstruction and hyperinflation. And during exercise, again, maximum heart rate, maximum R was the same. Turned out their maximal VO2 was not significantly different. Ventilation, not significantly different. Ventilation is a fraction of their maximal voluntary ventilation, not different. Rafika Humuchu Ursu, who was a pulmonary fellow 1998 to 2001, she studied, she's an overachiever here, 50 kids who had been treated with ECMO for neonatal respiratory failure versus 27 controls, mean age around 11, estimated gestational age and birth weight about what you'd expect. The reasons for ECMO in these babies were primarily Meconium aspiration syndrome, some sepsis and pneumonia, few congenital heart disease, persistent pulmonary hypertension of the newborn, and respiratory distress syndrome. In her study, total lung capacity was not different, vital capacity was not significant, but they were hyperinflated. They did show decreases in flow rates, and the children who had exercise-induced bronchospasm was significantly greater in the ECMO group than in the control group. Neonatal lung injury impacts subsequent lung development. Neonatal lung injury results in long-term pulmonary function abnormalities, primarily airway obstruction, hyperinflation, and bronchial hyperactivity were the most commonly seen. Variation in VQ is due to non-uniform distribution of ventilation. Distribution of ventilation is altered by airway obstruction or decreased sensibility. Compliance equals change in volume over change in pressure. Elasticity, surface tension, and pulmonary interdependence are the main features, and decreased compliance is stiff lungs, small volumes, and restrictive disease. Airway resistance equals change in pressure over flow. 80% of airway resistance is in large airways. Maximal expiratory flow is limited by airway resistance, elastic recoil, and lung volume. And the time constant, abbreviated Greek letter tau, is resistance times compliance. The best ventilated regions of lung fill first on inspiration and empty first on exhalation, so-called first in, first out. Ventilation and perfusion are highest in the base of the lung, but there is a steeper gradient for perfusion, so VQ is highest in the apex. Worker breathing is pressure times volume. The equation of motion of the lung, transpulmonary pressure equals volume divided by compliance, which is the elastic component, plus resistance times flow, which is the resistant component. The respiratory pattern is associated with the lowest worker breathing. Full-term infants are born with only 10% of alveoli, 90% being added after birth up to about age 18. Postnatal lung development increases alveoli and surface area available for gas exchange. The same disease etiology causes different clinical conditions depending on the developmental state of the lungs, and infant lung disease causes long-term sequelae in lung function. Summarizing mechanics here, decreased sensibility, stiff lungs, small lung volume, they're difficult to inflate, increased worker breathing. Increased resistance is airway obstruction, narrow airways, decreased expiratory flow, and increased worker breathing. And again, distribution of ventilation affected primarily by decreased sensibility and airway obstruction. So next time, we'll begin talking about pulmonary function testing. And we're going to go into a fair amount of depth here. So we're going to talk about how these tests are measured and go over some of the things that would be important if you're interested in running a pulmonary function lab. The next time will be pulmonary function testing 1, which will be primarily an introduction. And then we'll get to some specific tests after that. So thanks again to our producer director, Katie LeWinter, and thank you so much for joining us in this exploration of pulmonary mechanics.